Hey guys, welcome to my channel. Let's enjoy Dr. Y Chest Radiology. I'm Dr. Y, Medical Professor, Chest Radiologist, Seoul, Korea. Chapter 50. Today we're gonna talk about lung cancer TNM staging 9th edition, especially about T staging. Let's go. Let's look at these two pictures. Actually, we all know and familiar with these two normal, healthy, and happy young men and women's chest radiographs without abnormal findings. So we all hope our thorax itself to be like this, and this is the gold standard for our interpretation of chest radiographs. But how about these two pictures? It is abnormal, painful, and it is served as sorrow, lung cancer. And these are the cigarettes on the convenience store. What are written on the surface of the bag? Discoloration of the teeth, sexual dysfunction, fetal malformation, laryngeal cancer, oral cavity cancer, shorter lifespan, heart disease, lung cancer, stroke, etc. This is abnormal, painful, and sorrow. So let's get out from smoking, tobacco, and let's start chapter 50, non-small cell lung cancer, TNM staging 9th edition. T is talking about tumor size itself and the extent of tumor involvement. These are the topic of today, and N, lymph node, and M, distant metastasis. We will talk about NM staging later next session. On year 2023, World Conference on Lung Cancer in Singapore, they finally proposed for 9th TNM classification. Actually, there was no change on T descriptors. On N descriptors, they split N2 into N2A and N2B. And on M descriptors, they splitted M1C into M1C1 and M1C2. We'll talk about it later. T staging of 9th edition is same as 8th edition. Let's start with T1 staging. T1 means the tumor size is less than 3 cm, surrounded by lung or visceral pleura, not involving main bronchus. T1A means up to 1 cm in size. T1B is up to 2 cm. T1C is up to 3 cm. 1, 2, 3. It's easy, quite easy. Let's begin our wonderful trip about T staging in the Chest Radiology Museum. How about this picture? Do you see something here? Very small, very small. On the CT, we see 7 mm night upper nodule. So this is T1A staging. There are emphysema around here and here, so he must be a smoker. Relatively, he is a very, very lucky guy because it is T1A. Now we see something here, this one. On the CT lung window setting, there is a nodule 12 mm in length, right middle of. It was confirmed as adenocarcinoma, so this is T1B staging. On this chest radiograph, do we see something? Something vague? Something suspicious? On the thin section lung window setting CT, we see part solid, subsolid ground glass nodule. Solid portion length is 13 mm. As we see on adenocarcinoma of subsolid nodule, we measure solid portion, not pure solid portion. only solid portion is measured for staging, so it is T1B, although the total length is more than 2 cm. How about this one? There is a nodule on right upper lobe. This one. Yes. On axial CT long window setting, we see 23 mm SPN with speculations. When we staging the tumor, we disregard this speculation as lengths. We measure the round mass only. So this is 23 mm, so it is T1C tumor. Let's move on. T2 staging is like this. Tumor length is up to 5 cm in any dimension of the longest one of MPR image, or involvement of main bronchus without involving carina, regardless of distance from carina, or invasion of visceral pleura, or atelectasis, or post-obstructive pneumonitis extending to hilum. T2A is up to 4 cm in any dimension, longest dimension, and T2B is up to 5 cm in length. How about this tumor? On axial CT, right lower lobe superior segment, the longest length is 35 mm with speculations around it. This is adenocarcinoma, so this tumor is T2A because it is less than 4 cm. Let's talk about visceral pleural invasion of two different patients. Visceral pleural invasion means T2. This is right upper lobe with speculation attached to visceral pleura. And this one is left lower lobe nodule with speculation attached or maybe invasive to pleural side. Actually, with these two images, we can suspect whether it can involve the visceral pleura, but we need surgical or pathologic evidence of real, true invasion of visceral pleura. So, visceral pleura invasion is not always correct with CT findings. How about this one? 48 mm on left lower lobe axial image, 48 visceral invasion surely here. So this is T2B because it is less than 5 cm. This is one of the most famous lung cancer chest X-ray findings, usually suggesting old man, heavy smoker with squamous cell carcinoma in right upper lobe, showing obstructive pneumonitis, Dr. Golden's S sign, reverse S sign. This one, inverted S sign. This is T2 due to obstructive pneumonitis to hilum. How about this picturesque image of lung cancer of left upper lobe collapse? Actually, this is the mirror image of previous Dr. Golden's S of right upper lobe collapse. The tumor is left upper lobe bronchus, squamous cell carcinoma, obstructing here, showing orthodox S sign. On coronal CT image, there is tumor here from upper lobe bronchus to the distal main of left bronchus, and carina is okay for now, so this is T2 stage tumor. Let's have a short intermission, enjoying picture wonderful paintings of Pierre-Auguste Renoir. You all know, I think you all know about this picture. Yes, very happy, present environment, mood, interesting talking, happy face, happy face. There are some boats over there on the river. Yes, this is the famous Painting of Renoir. This is my favorite. Luncheon on the Boating Party, 1881. The Phillips Collection in Washington, D.C. This picture is from Wikipedia. These all people are the friends or some even fiancé is here, all are very familiar with the painter Renoir. The models are familiar with Renoir. This is the happiest painting ever I've seen before. I'd like to tell you about the lung cancer. Seriously, I mean it. Lung cancer is not easy to detect in early stage. Lung cancer usually shows bad results, usually. We all hope to conquer the lung cancer disease. And quit smoking is the best policy for now. And 5. Lung cancer is slowly improving in prognosis recently, but not perfectly. You quit smoking? Congratulations! Of course, you subscribed. Thank you very much. Be happy always. Let's move to T3 staging. T3 means up to 7 cm in greatest dimension, or tumor of any size that involves chest wall, pericardium, phrenic nerve, or satellite nodules in the same lobe of the tumor. How about this picture? Squamous cell carcinoma of right upper lobe with 6 cm in longest dimension, 6 cm with pleural invasion. So this is T3 in length, size of the tumor. How about this one? Left upper lobe peripheral lung cancer invading rib. So we are seeing rib destruction here, chest wall destruction. So tumor here with rib and chest wall destruction, invasion. This means T3 staging. How about this picture? This is also the one of the famous or characteristic picture of lung cancer with a mass here in the apex with rib destruction. We can diagnose as superior sulcus tumor of right upper lobe. This is squamous cell carcinoma. We used to call it Pancoast tumor, but we usually now say as superior sulcus tumor. This tumor usually shows pleural and rib invasion of severe pain. So this is T3. If this tumor is bigger than this and invade more artery or veins of subclavian artery or vein or brachial plexus, it becomes T4 staging. Now let's move to the final one, T4 staging. T4 size is more than 7 cm in greatest dimension, or any tumor with invasion of mediastinum, diaphragm, heart, great vessels, recurrent laryngeal nerve, carina, trachea, esophagus, spine, or separate tumor nodule in different lobe of ipsilateral lung. There's a tumor on left upper lobe here, and there are separate small daughter nodules here, tumor nodules. So this one is T3. The same patient, and he also has nodules on left lower lobe. This means T4 staging. Actually, this patient is T4 staging. How about these patients? We can easily understand that all of these two patients are T4 because on our left side, right upper lobe, this tumor is 8 cm, more than 7 cm. On our right side, this tumor is 9 cm. On the left lower lobe, more than 7 cm. So all these tumors are T4 staging. Now let's talk about the mediastinal invasion of two different people. The first one is left upper lobe lung cancer, diffusely and broadly invading mediastinum. This is T4 staging, and also see the left diaphragm elevation, meaning phrenic nerve invasion. This is T3. And another patient with a left upper lobe tumor with broadly invading, diffusely invading mediastinum, mediastinal invasion. So this is T4 staging. Both patients are inoperable for now. Let's look at the coronal image of left lower lobe showing diaphragm invasion. This one. This tumor of left lower lobe invades diffusely this left side diaphragm. This one is T4 staging of poorly differentiated cell type. How about this one? Intrapericardial pulmonary artery invasion here. This is T4. And right upper lobe apex tumor invading not only pleura but also vertebral body. Vertebral body invasion means T4. Let's have a short time thinking about the tumor size, tumor length, and tumor T staging, and the number of tumor cells. We all know about the volume of the ball. Ball is solitary pulmonary nodule or maybe mass. Pi r 3 square. 2r means diameter. 1 centimeter is T1A. Tumor cells number can be regarded as 1. How about T1B, 2 centimeter? The tumor number will be 222, so it becomes 8. 8 times more than T1A. And how about T1C? 333, 27 times more than T1A lung cancer in cell number. How dangerous? Let's think about the T4, 8 centimeter, 888, 512 times more in number of cancer cells. How terrible it looks in number. So T staging should be possibly less. Less is much better for treatment and prognosis. Subscribed? Thank you very much. Quit smoking? Congratulations. Feliz Navidad. Why don't you have a party for your quit smoking with your family and friends today? Thank you very much.